great to move on to our next section. It's a great privilege to introduce Professor Michael Glikson from Jerusalem, Israel, who's going to focus on the CRT element to the guideline. Of course, he was the chairperson for the guidelines. Thank you very much for joining us.
Thank you. So my task today is to cover the CRT, to focus on CRT part of the guidelines. This was the group that authored the guidelines. It was a 2-year work, quite tedious, but I think it was very successful. And also, I did not list the reviewers. Cecilia led the committee of reviewers, which also did a lot of work. So let's review some of the recommendations that we made. The first and clear recommendation, of course, it's a Class A recommendation for the classical CRT candidate symptomatic patients, meaning NIHA class 2 or above, in sinus rhythm, LV ejection fraction below 35, QRS above 150, LBBB morphology, despite optimal medical therapy. We did not specify the duration of time of optimal medical therapy, and CRT is indicated to improve symptoms and reduce morbidity and mortality. Let me just go back one step and mention that our guidelines regarding CRT are in line with the CHF group. The guidelines for CHF were published at about exactly the same time, and there was a lot of work to line them up together. There was a lot of discussion, some arguments, but we finally were able to reach an agreement, as opposed to previous sets of guidelines where there was some disagreement between heart failure and EP guidelines. So we'll move on with the indications. It's a 2A indication, same patients, but with somewhat narrower QRS, 130 to 150. Otherwise, the same as this first group here. It's a 2A indication to improve symptoms and reduce morbidity and mortality. And again, the lowest number is 130. We don't go below it. For non-LBBB QRS morphology, we recommended a 2A indication to improve symptoms and reduce mortality in patients with heart failure in sinus, ejection fraction below 35, QRS duration above 150, and non-LBBB QRS morphology despite optimal medical therapy. This is a 2A indication, whereas the same group with somewhat narrower QRS, 130 through 150, we recommended a 2B indication. Still possible, but much less indicated. Whereas CRT, as we all know, is not indicated in patients with QRS duration below 130 due to increased morbidity and mortality shown in previous studies. Regarding patients in atrial fibrillation, we are looking here at the indications for CRT. One group is a group of patients with atrial fibrillation who do not need, and again, we're assuming that these are patients beyond the option to do AFib ablation. So it has been agreed that this patient is not a candidate for AFib ablation. He remains in persistent or long-standing atrial fibrillation. Some of them do not need a rate control by nodal ablation, but they need a CRT for heart failure. Then we implant a CRT. The indications in patients with atrial fibrillation are a little different. First of all, we recommended implanting CRT only for NIHA class 3 and 4. We thought that the evidence for NIHA 2 were a little too weak. The other thing is that I'm not sure whether everyone is aware of it, but in work on atrial fibrillation and CRT, there wasn't a great difference between the different QRS morphology. So regarding the indication to CRT in patients with atrial fibrillation, it's the QRS width that determines the need. It's QRS width above 130, but there is no referral to morphology. So all morphologies with wide QRS, NIHA class 3 and more with atrial fibrillation are eligible for CRT. And then if you're able to pace above 90 to 95% of the time, then it's fine. Otherwise, you have to go to AV nodal ablation to enable the CRT to operate. The other column here refers to patients who need AV nodal ablation to control their rate. And then we are looking at the appropriate pacing system that they need. If the ejection fraction is above 50%, then RV pacing is the recommended mode. And CRT and or his bundle pacing is an option, but RV pacing is the one that we recommended. If the ejection fraction is below 40, then the first recommendation is for CRT. It's a different level if it's below 50 or below 40, but generally speaking, ejection fraction below 50% is CRT is recommended, and a lower level of recommendation is given to his bundle pacing because of lack of evidence so far. But anyone who starts with an ejection fraction that is lower than 50 and is going to undergo AV nodal ablation needs a CRT according to our recommendations. Just to put it in text, that in patients with heart failure and permanent atrial fibrillation who are candidates, CRT is for ejection fraction less than 35, NIHA class 3 or 4, we don't include NIHA 2 on optimal medical therapy, QRS above 130 without referring to the morphology. AV junction ablation should be added if we cannot reach more than 90 to 95% of pacing due to atrial fibrillation. In patients with symptomatic atrial fibrillation who are not uncontrolled heart rate, who are candidates for AV junction ablation, CRT recommended, as I mentioned before, in patients in whom the ejection fraction is reduced, CRT rather than standard RV pacing in those who are between 40 and 50%. RV pacing should be considered if the ejection fraction is preserved. And at a lower level of recommendation, you can also consider CRT in patients with normal ejection fraction, but we thought it was a little too far. Therefore, we gave it a 2B indication. How about upgrades from right ventricular pacing to cardiac to CRT? There are quite a few publications, although most of them are not randomized controlled. Patients who have received a conventional pacemaker or an ICD who develop symptomatic heart failure, NIHA 2 or more, with ejection fraction that drops to less than 35% despite optimal medical therapy, and who have a significant proportion, we thought that more than 20% is enough for a decision to upgrade to CRT. We did not refer specifically to CRT or CRTD in this particular population because, for example, if someone has a pacing-induced drop in ejection fraction to somewhere between 30 and 35, we all know that is very likely to increase to the high range, out of the ICD range, if you just upgrade to CRT, because these patients tend to respond very favorably to upgrade. Some of them are indeed super responders, but we left it up to the operator to decide whether it's just an upgrade to CRTP or to CRTD. Those who come in with AV block and have heart failure already, and you have to decide what system to implant, we recommended CRT rather than RV pacing in patients who have an ejection fraction below 40%. Regarding of the near class, who have an indication for ventricular pacing and high degree AV block. This includes patients with atrial fibrillation. There was a discussion of whether we shouldn't include patients with up to 50% because there were studies, at least one big study that showed benefit starting as high as 50%, ejection fraction of 50%, but most of the patients included were actually below 40%. So we decided to pick 40% as the limit of CRT, above which one may still consider implanting an RV pacing or else conduction system pacing. But everyone who's below 40% should receive a priori a CRT device. Regarding the issue of combining it, whether a CRTP or CRTD, we actually listed the arguments. So we thought that if a patient is a candidate for ICD and also has a CRT indication, he should receive a CRTD. And in a patient who is a candidate for CRT, consideration should be taken whether a CRTD should be implanted or just a CRTP. And we provided the readers with this scheme rather than specific recommendation. We listed the arguments in favor of CRTP versus CRTD in a CRT candidate. Do we have to implant a pacemaker or an ICD? So the parameters for this consideration include the age. As the age is older, we tend more towards CRTP. As the myocardial fibrosis on CMR, if there is a CMR, is higher, then we tend more towards CRTD. And there are several other arguments, such as non-ischemic cardiomyopathy, that is more towards CRTP only, short life expectancy, CRTP, major comorbidity, CRTP, poor renal function, probably also CRTP, and patient preference. So we have to take all these together when we consider whether a CRT candidate should receive CRTP or CRTD. And in fact, the last two slides are about his-mounted pacing, but they were already covered by Kevin. So I think that I can finish at this point. Thank you very much.
Thank you very much, Professor Glikson, for an excellent overview and also for the body of work. I'm sure it was a labor of love. I have a few questions, and I'd be interested in the panel's views as well. You talked about the LV impairment being obviously the ejection fraction clearly being critical in a decision about whether one goes for a regular pacemaker or CRT. Do you, in your current practice, do you use less than 40%? Because I certainly know that a lot of colleagues will use anything that's abnormal, so anything less than 50%. I presume that the reference that you made was to block HF, and the mean of that patient group, as you said, was mostly, I think, certainly less than 40, 45, but they did extend it out to the 50%, 55%. So I'm just interested in practical terms what you do, and also colleagues on the panel.
To be honest, we adopted the 40%. It's also a practical issue. I mean, if you decide although we know that CRT is now done everywhere, it is still a little more complicated, more time consuming. It's a burden to get organized for CRTP in any patients with any reduction in ejection fraction. And these are all, we're talking about urgent patients. It's a patient who comes in with AV block. Are we set to do CRT in all? It's kind of convenient for us to use 40% rather than 50%. And because this would increase significantly. If we adopted 50%, it would increase significantly the need for CRT at any time of the week or the day. And we are not convinced of the real value because it's only one study and just the minority of the patients who are actually in this range of ejection fraction.
I think also there's obviously also a standard deviation of any measurement in a study, and even though it was a large study, you have that to consider too. I think those practical considerations are, of course, important, particularly operator training and out of hours capability. Professor Linde, Professor Vernooy, what do you do in your centres?
So we don't have operation possibilities 24 hours, and also not the lab that we want to do CRT in is only available in one of the two units, that is Karolinska. We are doing much like Michael it is determined whether the acuteness of the procedure. But if we do have a little bit more time, then we probably implant the CRT in somebody with ejection fraction as high as 40, even 45%, if we firmly believe this is a person who's going to benefit from CRT. This is going to enable that person to have optimal medical therapy to full extent, which is important in heart failure patients.
Yeah, actually, in Maastricht, we've been doing actually for years that we have the cutoff of 50% of ejection fraction. And we have, but of course, it's also about the logistics. We have everyday availability of CRT implantations, not during the night and evening. Then we do temporary lead if necessary for these AV block patients. But otherwise, during the day, we would implant a CRTP in patients with ejection fraction below 50%. However, as I said also previously, now with the new conduction system pacing, we have this intermediate group between 40 and 55. Then we are more, we easily go for left bundle branch pacing because we think that's a good group that you have to kind of stay away from more leads. And there's now an additional therapy potentially available.
One more comment. When dealing, as you realize, when dealing with patients who are going for AV nodal ablation, we elected to choose 50%. Rather than 40%, because this is an iatrogenic AV block. There were a lot of discussions on this one as well, because when you do AV nodal ablation, there is some improvement in ejection fraction just because of the rate control. Nevertheless, because it's an induced AV block, and also several publications that used 50%, that we elected to recommend 50% for CRT in patients who are undergoing AV nodal ablation. Not entirely consistent, I must admit, but we ended up with this recommendation.
So I understand the rationale for that. I'm interested by what people think the actual the figure, the prevalence of pacing-induced cardiomyopathy is of patients who you've committed to cause iatrogenic block and you're pacing all of the time. I certainly remember some studies suggesting about 10 to 20%, but I don't get a feel for whether that's. I suspect that's probably right. Do you have a feel for whether you think that's about the rate, and why 80% of patients don't get it? Because we know it's desynchronous, so surely it's a bad thing.
I think that the number is correct. This is what I remember as well from several works in the past. Why? I'm not sure. I mean, there were quite several groups that were able to identify risk factors, such as the underlying conduction pattern and so on, but in previous ejection fraction. But I don't think that we have one or definite score or criterion to predict it. Again, with AV nodal ablation, you expect some improvement just by controlling the rate. So I think and you may argue for, I mean, in the borderline group, you may argue for implanting regular pacemaker and then upgrade if in the 10 to 15% there's deterioration in function.
Yeah. I guess I know some people would certainly argue to put 3 leads at the or to put the CRT at the onset and then not have to do an upgrade with potential central venous occlusion, which is an issue later on. But I suppose we don't know for sure. It's just an interesting point that in a significant chunk of patients, actually, when you pace them, their LV function doesn't get worse. And I'm not sure I fully understand that, but I'm not sure anyone does. One of the other things that I think is really interesting, particularly across Europe, where I think there is quite a variation, so I'm interested to know your answer, is the P versus D argument. You produced a really nice panel in the guidelines. I think it's very practical and very useful, and each of us may have our own practices. But I'm just interested in your own centers, in your own in your country. Is there a preference, do you think, from colleagues, and what are the motivations that drive that?
Can I just start by saying that we know from CRT survey, which we did in 42 countries, that the use of CRTD is relatively widespread. It doesn't only depend on economical situation, but it's actually probably a function of key opinion leaders in that country. But on the average is somewhere around 70%. I think it's important, and this guideline has done a real good job of that, of introducing the patient perspective, because the patient, once given the facts, may not actually want a CRTD, even though the doctor may think that that's all the best in everyone. So I think it is definitely linked to more complications, no doubt about that, inappropriate shocks. And for women, perhaps not even enough benefit, because there is less arrhythmia in women and less shock delivery in ATPs in women, and better propensity of improving by CRT. So I do think that the shared decision making here has a big role to play. That is one aspect. And the other aspect is that if it's possible to do an MRI workup before implanting the CRT, I think that's excellent, because then you know about scar extent, and because after the implantation you cannot do that workup. So I think that is one of the important things as well.
No, I fully agree with Cecilia. I think we should more carefully evaluate our patients before implantation. I try to systematically perform an MR before implantation, especially with a dilated cardiomyopathy without any scar. The evidence is there's actually no evidence that CRTD is better than CRTP, and we could potentially much more implant that device rather than a D. However, I see that still, and I think it's still awareness and training education of all cardiologists in the country, because the referrals are still very much directed towards CRTD as soon as a CRT is indicated. So I think there's still much to learn, and much more awareness to create on potential side effects from the ICD, rather than saying when we implant, we'll provide you with the best device that's possible.
Can I add another aspect? We now have 2 new heart failure drugs which reduce ventricular arrhythmia and induce reverse remodeling. ARNIs and the SGL2 inhibitors. And so that's also an aspect to bring into this equation, I think. If you really treat patients properly, then perhaps the need for ICD therapy will not be nil, but it will be less.
Yeah, I think that's a fabulous point, and I was actually just going to ask you all if you thought if we repeated some of the CRT studies now with the ARNI and the close-ins, etc., and the various heart failure medications, if we repeated them, whether the baseline placebo improvement would be better. You would assume so, and therefore what the gains from CRT would be, and therefore what would be the actual gains from a defibrillator in this population. I'm not sure we know, but I'm interested to know whether that would influence things, because things are different now.
Well, there is also reason to believe that left bundle branch block patients respond less to heart failure medication and more to electrical therapy. So it may be that these patients with true desynchrony do not have exactly the same benefit as somebody with quite normal conduction.
I agree. I think the electrical desynchrony is one of the major problems. Always there's hypertension, there's scar, there's more characteristics that probably will develop, create the heart failure to develop. But I think you really need to treat the underlying conduction disturbance to really improve those patients. So therefore, I still believe that probably CRT will still have an additional effect in these heart failure patients, although the effect might be relatively less because, of course, the mortality numbers have gone down over the years. But I still believe that the relative improvement could still be present when we would redo the studies on CRT.